Thank you, Alok. Thank you so much for this very nice presentation. It's an honor for me to be here with you to try to explain some functional uses of lung ultrasound in our neonates, not just diagnosis, as he was saying, but also relating to other uses that we can give to lung ultrasound to monitor very low birth weight infants after birth and after the initial phase of RDS. Just before I begin, let's say that this conference that Alok was saying will be held in Rome this year, probably not in October, but in 1st November. So all of you are invited to attend online or in person, or bring your communications, because it's a really nice conference if you are really kind of both pediatric and neonatal lung ultrasound. So let's begin. We would first talking about how lung ultrasound progresses in our tiny babies, in infants born before 32 weeks gestational age, and to understand how we can use it to predict bronchopulmonary dysplasia in our population. And we will also have a few words at the end of the talk about how can we use it also to monitor response to some medical treatments that we may have or we may administer to these patients. All publications relating to the functional use of lung ultrasound are based in the lung ultrasound score that you all may know about the classes of RDS. But just to remember, it's a function, a kind of score that we may calculate using semi-quantitative assessment of lung aeration, and we evaluate how the lung is progressing in different areas of the lung. This is the classical distribution of areas that we use in the classical lung ultrasound score, which was first published trying to predict surfactant treatment in preterm infants, in which we evaluate 3 areas in each lung: upper anterior, lower anterior, lateral, combining both intermammillary lines, anterior axillary line, and posterior axillary line. In each field, we give a number which corresponds to the aeration that the lung has in this area. And it ranges from 0 to 3, as you may see here, which 0 would be well aerated lung with thin pleural line, few B lines less than 3 B lines in each intercostal space, that would move to 0.1 when these B lines increase in number to more than 3 between each ribs. And then when this a crowded B pattern, then we transfer to number 2, or even small consolidations at the level of the pleural line that move to number 3 when they are big consolidations that resemble to this image here that I shown as a graphic. And zooming all together, all 6 fields evaluated, we can get a number which ranges from 0 to 18, but we can modify this, changing or adding new fields according to the type of score that we want to calculate. So using this approach, we may calculate, we may see the progression in lung ultrasound score in very low birth weight infants. This publication that calculates, in which we calculated lung ultrasound score progression in infants born before 32 weeks, you can see that according to the final diagnosis of BPD in different populations of preterm infants, and monitor them seriously since birth, at 3 days of life, and then weekly, you can see how those both groups of infants have an increase of lung ultrasound score in the first days due to the initial phase of RDS in respiratory distress syndrome. But after that, the infants that don't develop BPD do have a decrease in lung ultrasound scores that remain low through the rest of the follow-up, with significant differences with those that do have BPD, in which at the moment of the red arrow is signaling at 1 week of life, you may see a difference in progression in those infants with and without BPD, in which the last group do have these persistently high lung ultrasound scores in the follow-up. But this is not the case in all preterm infants with chronic lung disease progression. As you may see in this other study, we compare the evolution of infants according to their gestational age to chronic lung disease of the need of oxygen at 36 weeks postmenstrual age. And they also were monitored at birth and then 3 days of life and then weekly. And those infants that were independently of their gestational age, those that do need oxygen at 36 weeks postmenstrual age do have this lung ultrasound scores persistently high, though a bit reduced in those infants that were born after 38 weeks gestational age. However, those that don't need oxygen at 36 weeks postmenstrual age do have different progression according to their gestational age when they were born. More mature infants have this progression that we've seen in the first slide, in which lung ultrasound score were increased at birth and they decrease afterwards and remain low. You may see this is the predicted progression using regression analysis. And those infants born before 38 weeks, which are those with high risk of BPD, even though they don't need oxygen at 36 weeks postmenstrual age, do have persistently high lung ultrasound scores in the first month of life. This is a normal progression that should be differentiated from infants that are born more maturely. After this first month, they do have a decrease of lung ultrasound scores, and we have to understand this progression when we are monitoring these infants and we are trying to get the risk of developing chronic lung disease. We also have to face that we can use this serial progression to monitor when an infant's ready to be weaned from invasive or non-invasive ventilation as well. This was an example. This is a 36-week, this was a preterm infant born at 36 weeks, which is now about 1 month of age. And you can see that this is the normal ultrasound exam in this population after the first 4 or 5 days of life, in which you can see this is the upper anterior, lower anterior, and lateral fields in the left lung. You see this is a thin pleural line without consolidations, increase of B lines. This is an interstitial pattern in which we don't see nothing special, nothing that deserves a bad prognosis for this baby. This is the right lung in the same baby, the same fields evaluated, right, upper anterior, lower anterior, and lateral field. No consolidations, but this increase of B lines that corresponds to the need of respiratory support that this baby still has when she's 1 month of age. And this progression of lung ultrasound score is also more or less the same, irrespective of the need of surfactant in the first hours or day of life. As you can see here, this is a huge population of infants born before 32 weeks, in which we divided them according to the gestational age that they had at birth and the need of surfactant. I mean, the developing of a severe form of RDS in which the infant needs to receive surfactant as a rescue treatment. In the more mature population, they will progress as we may think that lung ultrasound should progress, because if they need surfactant at birth, they have lung ultrasound scores that decrease afterwards. And if they don't, they do have low lung ultrasound scores through the whole follow-up. However, those infants born more immature, those born before 38 weeks, those that had surfactant also have high risk of developing BPD, and they have high lung ultrasound scores in the first month of life and a decrease afterwards. But those that don't have need of surfactant, don't have a severe form of RDS at birth, or even no signs of RDS, do have lower lung ultrasound scores at birth and 3 days of life. They show this increase in lung ultrasound scores afterwards that remain higher, and when they get to the 1 month of age, there's a new decrease of lung ultrasound score. And what do they have? Why do they have this progression with this ultrasonographic description? We are more or less following the term that both Dr. Bancalari and Dr. Alonso described in 2012 about respiratory instability of prematurity. Infants born before 38 weeks, through most of our stay in our NICUs, do still need of oxygen or respiratory support, both invasive and non-invasive ventilation, more or less till they get till 36 weeks postmenstrual age or a bit before, because there are many reasons why these infants may have this need of oxygen or respiratory support after birth, and after the final phase of RDS is over. They may have or may not have a chronic lung disease, but there's multiple situations, multiple physiopathological issues that may do that these patients still need some kind of respiratory support, and we can monitor this progression of how the lung is getting aerated, monitoring progression of their lung ultrasound scores through our units. This is the only publication up to date that describes how lung ultrasound progresses after infants with or without BPD are discharged from NICUs. This is an Italian study in which the group compare lung ultrasound progression since birth at 14 days of life, then 36 weeks postmenstrual age, and after that at 4 months and 8 months of life. And as you may see, there's a difference, a huge difference in lung ultrasound scores in infants with and without BPD, even at 36 weeks postmenstrual age. But this difference gets narrowed when they get older, so as most infants with BPD have a normal lung ultrasound progression when the time goes by and when the infants are being discharged from NICU and have an increase of lung growth and birth weight, they may have a final normal progression of their lung aeration measured by lung ultrasound. So this will be more or less the description of how we can monitor lung aeration in very low bedway infants, trying to explain how can we use it to predict chronic lung disease in very low bedway infants. This is an ex-preemie, baby born at 25 weeks gestational age. At the moment of this exam, the patient is 2 months of life and he has need of oxygen. It's a moderate form of BPD, and you may see here, this is upper anterior, lower anterior, lateral, and posterior fields of the lung. And you see this is a heterogeneous disease in which some areas are very aerated than others. And mainly in more dependent areas, we may see this pattern of small consolidations, atelectasis all through the lung, related to the prolonged time being on a supine position. However, the idea of this session is not to diagnose BPD as Alok described, but to try to get the risk of these infants to progress to a chronic lung disease, to use different treatments or different medical treatments to try to reduce in the infants with high risk. And why do we want to predict and try to reduce BPD? Because BPD is related to a huge number of associated comorbidities. It increases nosocomial pneumonia, retinopathy of prematurity, increases the length of stay in our infants, increases mortality, increases cost of their hospitalizations, attention to the emergency department after being discharged. It also has some relationship with their neurodevelopment outcomes, but also affects both preschool and adult respiratory function. So this is a disease in which many different treatments have been tried without any specific cure for it. And we have not been able to decrease the survival of these infants without BPD, though we are able to increase the increase the survival of preterm infants in our hospitals. We are not being able to reduce those that survive without BPD. So with this approach, we want to describe how can we try to stratify a risk of having chronic lung disease, both using the classical lung ultrasound score that we've described before, and also the extended lung ultrasound score, in which we also take into account posterior fields of the lung, which we have explained are those areas with high risk of more severe form of the disease due to the position of these babies in supine position. The first publication was on this issue was a study by a multi-center group from France and Italy that analyzed more than 100 patients born before 31 weeks, in which the neonatologist performed lung ultrasound score in the first day of life at 1 week, 2 weeks, 4 weeks, and 36 weeks postmenstrual age. And they calculated both classical lung ultrasound score and extended lung ultrasound score in this population, but they divided it by gestational age, because we know that gestational age do have an influence in the progression of lung ultrasound score. And using this approach, they demonstrated that both classical and extended lung ultrasound score are different in progression in infants with and without BPD, as you may see here, with a decrease in lung ultrasound score after 1 month of life. And this is the diagnostic accuracy in this study of classical and extended lung ultrasound score at day 7, in which the classical and lung ultrasound score do has an area under the curve of 0.83 to predict BPD at 7 days of life, with the sensitivity, specificity, positive, negative likelihood ratios, and positive and negative predictive values, which resembles the numbers get for the extended lung ultrasound score. They also try to analyze when is the best moment to change from a classical to extended lung ultrasound score. And although the extended lung ultrasound score may seem to have better diagnostic accuracy compared to the classical, they only get significant differences at 1 month of life. In this other paper, published a few months after the first one, which is a multi-center Italian study, they also evaluated the same number of infants born between 35 to 30 weeks. They had similar area under the curve for BPD prediction at 7 days of life. But as you may see here in this graph, there's the chances of developing BPD are different according to the gestational age of the babies they have at birth, as we've been explaining all through this talk. Those infants that have a high lung ultrasound score in the first 7 days of life have different BPD risk depending on the gestational age they were born. Those born after 38 weeks do have higher risk of developing BPD if they have high lung ultrasound scores, but those born between 25 to 27, they don't have this increase of risk that we see in the more mature infants. And this is due to the fact to the progression of lung ultrasound score that we've described in the first minutes of this talk. In dark gray, we see infants born at 25, 27. light gray would be those at 21, 23, and middle gray would be those 28, 30 weeks that you see have intermediate progression between more immature and more mature infants. And using these publications and some others from our group, we published this meta-analysis in which we demonstrated that lung ultrasound score are useful for BPD prediction in the first 7 days of life with this pulse sensitivity and pulse specificity in infants born before 32 weeks gestational age. But we do not only have lung ultrasound scores when we evaluate a baby, we also have some variables related to clinical or respiratory measurements that we can also combine to both lung ultrasound scores. So this multi-center Spanish study, we combine some objective variables like gestational age and sex of the baby with lung ultrasound score at day 7 to increase the diagnostic ability of this approach for BPD progression, similar to combining some other subjective variables like the need of invasive mechanical ventilation at day 7 or an hemodynamically significant PDA or the developing of later sepsis at day 7. And this was also replicated as soon as 3 days of life, in which gestational age and sex can be improved as prognostic markers of BPD when we combine them with lung ultrasound score at day 3. If we think in the progression of lung aeration after RDS, those infants that do develop a severe RDS that can be described by ultrasound with this increase of lung ultrasound scores, more or less 3-4 days of life, these infants do begin to produce their surfactant. Those that don't have an improvement in aeration at 3-4 days of life are those with higher risk of developing BPD. And this was also replicated in another study from a Canadian group in which combining gestational age, sex, and the need of invasive mechanical ventilation on day 3, 7, or 14 do have this diagnostic accuracy in terms of area under the curve for BPD prediction as well. So now, after these theoretical minutes, we will also have some clinical cases for you to see how we do it and how to monitor the progression and the images using lung ultrasound in preterm infants born between 32 and 28. And we have some words about how we do it in the most extreme infants. These first 2 cases are 2 brothers born at 32 weeks gestational age that didn't require resuscitation at birth. They were born in 1,500 grams and 1,400. Both developed respiratory distress in the first minutes. Both received nasal CPAP, but the first one required higher need of FiO2. This is both anterior fields in each lung of the first twin. This is the left lung, and this is the right lung. You can see this interstitial pattern in more or less the 4 areas. And this is the second twin, both anterior fields in both lungs as well. And you see how this baby has better aeration, has a decreased level of lung ultrasound score. And as we were saying, that this one had reduced need of FiO2. This baby didn't require surfactant, but the other did by less invasive surfactant administration with positive response, and they do have normal evolution after this. The second twin required progression of respiratory support, non-invasive respiratory support due to apneas at 30 days of life. But at 3 days, we see this progression of lung ultrasound. These are the same again, more or less the ultrasound was the same in both twins. We also have both anterior fields in both lungs, and you see that the images are quite similar to the initial phase of RDS. They are still on non-invasive respiratory support, 21% of FiO2, but see the progression at 7 days of life, both twins. Though the RDS is over, they have still need of oxygen. They have an increase of lung ultrasound score after having received surfactant 1 and not the other. And these babies are high risk of developing chronic lung disease. And in fact, the first twin require nasal CPAP until 25 days of life, and low flow nasal cannula after that. And the second twin remain on nasal CPAP for 28 days without respiratory support afterwards. The third case was a preterm infant born at 31 weeks, born with 1,500 grams by emergent cesarean section due to maternal preeclampsia, received a complex course of prenatal steroids, and didn't require resuscitation at birth, but he was transferred to the NICU on nasal CPAP and didn't require surfactant. This is the lung ultrasound performed at 3 days of life. You can see, this is the upper anterior, lower anterior, and lateral fields. You can see this normal aerated areas all through the lung without almost any B-line, which is described in this baby that probably didn't develop RDS, but if he did it, it is over. And see the progression in the 7 days of life with this quite normal aerated lung in the 3 areas. So this baby had a failure of nasal CPAP withdrawal at 3 days of life, but we were able to remove non-invasive ventilation at 7 days of life and didn't require respiratory support afterwards. Another infant born at 28 weeks, she was a triplet born with 780 grams. She was born with her sisters by a cesarean section because she was developing IUGR. She required positive ventilation at birth, and she was transferred to the NICU on nasal CPAP. And this is how their lungs are progressing at 30 days of life. RDS is over. She didn't require surfactant, but she's still in non-invasive ventilation. And as you can see in these images here, both lungs do have not quite normal progression, but we can see an interstitial pattern in the 3 areas evaluated, both upper anterior, lower anterior, and lateral field, with a fragmented pleural line, an increase of B lines, and at least we don't see consolidations, but this is not a normal progression in this population. This is how it looks like at 7 days of life. More or less the same, a bit variated here, but we see small consolidations in this area and probably a whiteout pattern all through the lungs evaluated, all through the areas evaluated. She was still non-invasive ventilation until she was one month of life, and she received 2 more weeks of nasal CPAP, non-invasive ventilation again until 15 days of life. And after that, she was discharged home on oxygen. And although she was without respiratory distress at 7 days of life and with low respiratory settings, we are able to predict and to more or less stratify the risk of developing BPD in this baby just as soon as 7 days of life. And this is what we were describing before. It's not the same, the progression of infants born more mature than infants born before 38 weeks. Up to now, the clinical cases that we've seen are only infants born at 28 or afterwards. And but you see that the progression is not the same in infants born after this, before this age. Infants born at 33, 27, do have persistently high lung ultrasound scores, although they don't develop BPD at 36 weeks post-menstrual age. And we cannot use this lung ultrasound score only to stratify the risk of chronic lung disease. In this paper here, the group of authors evaluated not only lung ultrasound score, but also the number of consolidations, lung consolidations that the infants had. And they describe that the existence of lung consolidations are more frequent in moderate severe BPD. This is number of lung consolidations all through the follow-up, all through the stay in NICU. And number of lung consolidations before 1 week were also different between the two groups, and number of infants with more than 5 fields with lung consolidations were also different in the two groups. But we have to realize that in the first days of life, the existence of consolidations can be related to the diagnosis of RDS. So they also analyze number of consolidations between 1 week and 1 month. And you see that the difference are quite more challenging in between these two groups. There are also some signs that we may look for. We've seen a baby with a fragmented pleural line. And in this paper from a Chinese group, they also describe this debris lung ultrasound findings. This is not done early in the progression, but at 4 weeks of life. When we can see this fragmented pleural line and debris lung ultrasound features, this increases the risk of developing chronic lung disease more than 20 times than compared to just an increase of lung ultrasound scores. And this other paper from the Spanish group also described the number of consolidations on day 7 and on day 28. And you see how there's a significant difference in both groups in the risk of developing BPD really focusing on the existence of consolidations on day 7. This increases the risk from 2 times till 37 times of developing BPD in infants born before 28 weeks of gestation. So we will describe some clinical cases of more immature infants, just to explain you and to make you see what the difference are in this population related to the others that we've described before. This is a preterm infant born at 26 weeks, 960 grams, ectopic delivery, complete course of steroids that require intubation at birth due to low respiratory drive. She received 1 dose of surfactant and she was extubated at 12 hours of life, stable on non-invasive ventilation with low respiratory setting, but see how the left lung is appearing using lung ultrasound. Here you may see the upper anterior, lower anterior, and lateral fields of the left lung, and you may see that this pleural line is not thin. Well, it's mostly fragmented with very small consolidations. If you measure them, they are really less than 2 millimeters wide or depth, but they are here. They are showing us that this lung is not completely recruited. And we see this increased number of B lines, which are given a pattern of a severe alveolar interstitial syndrome, which is not really coupling with the need of respiratory support that the baby is having. This is the right lung, the same baby, also at 1 week of life. And you see that in all fields evaluated, the pleural line is fragmental with this debris sign that we've seen before. We see an increase of B lines, but we've seen that this is quite normal at this moment in this baby. But this is not that normal. When we find small consolidations fragmented pleural line do increase the risk of developing BPD. Same patient, the same fields, but 2 weeks of life. We have more B lines than at the first week, but we are still watching fragmented pleural line, a thick pleural line, not thin now, and an homogeneous progression of the lung disease in all fields evaluated, mostly in more dependent areas. This is lateral field in the right lung at 2 weeks. We see this big consolidation due to the position of the infant in prolonged supine position. This baby was quite stable, but we are not able to remove non-invasive ventilation until he was 36 weeks postmenstrual age. He received a low-flow nasal cannula after that, but we were able to discharge him without oxygen at the end. This is a 26-weeker, 850 grams, born by a twin pregnancy. He was born 3 days after his sister. It was a peculiar birth because the sister was born one day and the contractions stopped after her birth. So the gynecologist waited, and he was born 3 days after that. He also received a complete course of steroids, and he required a cesarean section due to the presentation, but he didn't require resuscitation at birth, and he was transferred to the NICU on nasal CPAP. This is a 3 days of life. It's also 26-weeker. See the differences that we may, if we think of the previous infant, in which the more or less B lines were similar, lung ultrasound will be similar because it will be #1 in the 3 fields evaluated. But see the difference in pleural line, which is thin, nice. It's all doesn't seem fragmented at all. We don't see any consolidation, no atelectasis, and this is a pattern of good prognosis. As we described before, lung ultrasound increases after the first days in this baby. It's a 26-weeker, but this is not a bad prognosis. This means that this baby is developing respiratory instability of prematurity, but we don't see consolidations, we don't see pleural line, and this is a pattern of good prognosis. Baby remains stable on nasal CPAP with low respiratory support. He didn't require an increase in the filters in our NICU, and we were able to remove non-invasive ventilation at 20 days of life without significant morbidities. This is not the normal progression that we see in 26-weekers, but it's possible as well, and we are able to more or less predict it using lung ultrasound as early as 7 days of life. This is a 25-weeker born with 650 grams. She was born by a cesarean section due to her presentation as well, and received also a complete course of prenatal steroids, but she required intubation at birth, and we were unable to extubate it at 7 days of life. And this is how the looks and her lungs look like, being on invasive mechanical ventilation. You see that these both anterior, upper anterior, lower anterior show an alveolar interstitial pattern with cholestin B lines, thick pleural line, but we don't see any consolidation. But in the lateral field, we can see this huge consolidation with a bronchogram that is saying this baby has been ventilated for a long time, and we don't have a good change in position, probably in this baby that has developed an atelectasis in this area. This is the right area of the lung, in which we are also watching some forms of small atelectasis and pleural line fragmentation here. And we're also watching this huge consolidation also in the right lung, which also has a bronchogram, but we also seen thread sign and a small amount of pleural effusion as well. We were able to extubate her finally at 1 month of life, and she received non-invasive ventilation until she was 39 weeks, was menstrual age, and finally she was discharged home with oxygen. This is a clinical case, the last one, a baby born at 25 weeks, 620 grams. This is the most severe case that we've seen in my unit, but this may happen as well. We've also described a 26-weeker without need of respiratory support after 20 days of life, and this is quite the opposite. She was born due to maternal neonates, with the mother being tested positive for Uroplasma parvum, which you will know that increases the risk of developing BPD, especially when mother develops neonates. She was born by vaginal delivery, and she required intubation at birth as well due to low respiratory support, and received 1 dose of surfactant in the first hour of life. These are the ultrasounds after birth. This is anterior, lateral, and posterior fields, in which you may see this clear and nice lungs in all fields evaluated, a bit more B lines in the posterior field, an interstitial pattern, but with completely normal aerated lung, both in anterior and lateral windows. This is 4 hours after having received surfactant, and the baby remain clinical stable. She was on low respiratory settings where we were unable to extubate her. She was also tested for Uroplasma parvum that was positive, and she received azithromycin for 3 days, although we know that doesn't improve her prognosis in terms of respiratory evolution. And although the baby remained quite stable and with low respiratory settings, as we described, this is the progression of lung ultrasound images. This is at 3 days of life. The baby already shown this thick pleural line with small atelectasis and increase of lung ultrasound score, although she was still intubated, and see how this is changing in 1 week of life, in which the pleural line is completely thick and gross. It's fragmented. We don't see consolidation, but we are already imaging an infant with clinical high risk of developing BPD with progression of lung ultrasound, which is in line with this back prognosis in terms of chronic lung disease. The baby developed a very severe respiratory form of respiratory disease with increase of respiratory support after 2 weeks of life. And at 36 weeks, she's still on invasive mechanical ventilation with FiO2 100%, inhaled nitric oxide, corticosteroids, diuretics, and so on. So as you are seeing here, this is some data from an American description of the progression in the numbers of apneas and episodes of intermittent hypoxemia in extreme repeat time infants. We have to realize that those born before 37, 36 weeks do have an increase in the number of apneas in the first month of life and begin to decrease afterwards. This is also related with moment when they are born. They are increase in those born more immature, and reduced number when baby are born at 28 or after that. But as you can see in this graph, they begin to decrease when we are seeing that lung ultrasound begins to improve. And this is more or less, and this is more the same with intermittent hypoxemia defined by oxygen saturation less than 80%, which is the fact that relates more to the risk of BPD in this population. You can see that they have an increase after that, after birth, that reaches the top more or less at 1 month of life, but begins to decrease afterwards. So this is more or less, it can be more or less have a parallel progression with lung ultrasound monitoring. We can monitor when lung ultrasound begins to improve when we can use it to reduce respiratory support or try to extubate our infants, our tiny infants. And just a few words about response of medical treatments that we use in our population. This is an abstract that we presented last year in the SNCC Congress in Athens, 2023, that include data from different Spanish NICUs. There were infants born, almost 15 infants born with a median gestational age of 25 weeks, and this birth weight, in which they receive steroids after birth to try to extubate them or decrease respiratory support. These are different moments of life, but you can see that this is the previous lung ultrasound exam before the initiation of steroids and the moment when they began with treatment. And you can see that in the first day after that, we see this decrease of lung ultrasound scores that remain low, although the treatment has already finished. In the red box is 2 or 3 days without steroids, and the purple one is 7 days without corticosteroids. It's a significant differences in lung ultrasound scores after treatment compared with scores before the initiation of steroids. This is a case that shows us this progression. This is a 25-weeker that required intubation at birth and was intubated until 1 month of life. She was on non-invasive ventilation until 36 weeks of menstrual age. This is quite a long time. And we monitor weekly using lung ultrasound in this baby. This is the ultrasound that we find every single day. This is left lung ultrasound and upper anterior, lower anterior, and lateral field. You can see no consolidations, no areas that we may recruit, but the baby still has this persistently alveolar interstitial syndrome with lots of V lines, and both in left and right lung. The baby was big enough, and we were unable to remove non-invasive ventilation. We decided to begin a course of steroids, and this is the ultrasonographic signs of her lungs 2 days after the treatment, after we began using steroids. And you can see how the lungs are greatly improved. And we see this thin pleural line with reduced number of B lines, both in the left and the right lung. So in this patient, after we removed steroids, lung ultrasound remained low. We were able to remove non-invasive ventilation 1 week after that, and we were able to discharge her without oxygen. And we can also use it to monitor the response to diuretics. These are also very low bed infants that receive diuretics due to many reasons. And we monitor lung ultrasound score some days before the initiation of treatment. This arrow here shows the moment when the babies were began on diuretics. You can see that there's a group of infants that were described as non-responders because we were unable to decrease the respiratory support after the initiation of treatment. But this group of responders, the group where we were able to extubate them or to decrease the amount of respiratory support that they were receiving, just in the first moment after when we began diuretics, we can see this decrease of lung ultrasound scores that's significant, that's statistically significant compared to the moments before the initiation of treatment. This other paper by an American group show similar approach. They calculated a lung ultrasound score, which is not the same that we've seen before. It is calculated just counting the number of B lines that the lungs have in different areas. And these are patients that receive diuretics or control patients with same gestational age. Sorry. And you can see how this lung ultrasound score decreases after the babies were began on diuretics. And this is the last case in which 26-weeker born with 730 grams by vaginal delivery. They were twins. She received a complete course of parenteral steroids, and she received 1 dose of surfactant by non-invasive administration and received non-invasive ventilation until day 7. However, at 36 weeks post-menstrual age, she's still on oxygen, and this is how the lungs look like. This is not a normal progression, as you may see. This is a severe form of alveolar interstitial syndrome with a thick pleural line, small consolidations, and lots of B lines in all areas evaluated. This is anterior field, lateral, and posterior fields of the lung. And this is how the lungs look like after she was began on diuretics. You can see that the pleural line has been improved. It seems thinner, and the number of B lines have been reduced as well. And we can see better aerated lung with some A lines in all fields evaluated. So as to zoom with, we have described how lung ultrasound progresses in infants according to gestational age, with different progression when they are born extremely low birth weight infants compared to those born with very low birth weight. To try to predict the risk of developing BPD, we can use lung ultrasound score in more mature infants, those born after 38 weeks. When we don't see a decrease in lung ultrasound score after the first days of life, we may see that these patients have an increased risk of needing oxygen at 36 weeks post-menstrual age. And in those born before 28 weeks, we also have to combine lung ultrasound score with pleural line evaluation and the existence of consolidations as well. And finally, after that, I would like to know that you've realized that we can use lung ultrasound to monitor the response to medical treatments, both steroids and diuretics that we give in our infants. This is my group of collaborators, and which I would like to thank in all my talks for the help. And I hope that you all enjoy it and ready to listen for your questions. Thank you.
Thank you, Dr. Almudena. That was absolutely fantastic. I am going to head to the questions because we have quite a few. So, Dr. Bavinseva, do you want to unmute and do you want to ask your question? If you could just introduce yourself and ask.
Good evening.
Hello.
I'm sorry, I'm confused a little bit. Thank you for your amazing presentation. And I'm a Ukrainian doctor. I'm a neonatologist and professor of our Ukrainian State Medical University. And I have 2 questions. First, could you recommend some guidelines, European or international guidelines for management of newborns with BPD? Because, for example, in my country, we have problems which of the correct dose of corticosteroids, correct dose of diuretics, and day of start to use this medication, which is better.
Thank you for your comment. They're not. We don't have published clinical guidelines with the use of steroids or diuretics, and the existing evidence is quite different. But the most used approach is to use mostly dexamethasone for infants that still are intubated after 7 days of life, because they are the group with high risk of developing BPD. We try not to use them as soon as 4 or 5 days, because we know that this has an increase of secondary effects and reduced benefits, combined with increased risk of intestinal perforation and so on. So the most used approach is to use postnatal steroids mainly dexamethasone in infants after the initial 7 days of life. But there's a new meta-analysis that appeared a few weeks ago, in which some authors have described that the infants that would benefit most are those who are born by a mother with suspected chorioamnitis or an histological confirmation of inflammation. So prenatal inflammation has the greater risk nowadays of developing chronic lung disease, and those patients will benefit more of the use of postnasal corticosteroids. However, this is something which is now changing day by day, but more or less the international convention is to use them after 7 days of life, in the second week of life, 7-14, when they are still being on invasive mechanical ventilation.
Thank you. Which of the dose do you recommend?
Sorry?
Dose.
Dose. Well, this is not. I see that Alok is laughing. This is not international consensus on that. But the most used is I'm sorry, I don't remember the acronym.
The DART protocol?
The DART protocol, thank you. This is the most used approach, which is 10 days, in which we have the first days with high dose, and we have a decrease after that. And this is the dose with less secondary effects and higher benefits in preterm infants.
I had a question on that, Almudena. So in particular, because you've been working on doing lung ultrasound in the first 30 days with serial progression, I'm just curious. I mean, initially we would have a lot of babies on invasive mechanical ventilation. Morphology, the lung ultrasound scores, does that influence your approach as well in terms of use of steroids?
Yeah, the baby that I've shown you in the last case, well, it was not the last case, it was in the severe form of the disease. We began that baby on steroids soon after birth when we show the progression, but this has not been studied in prospective clinical studies, so we cannot, make a
recommendation,
evidence-based recommendation to use in all extreme infants. We are trying to demonstrate in another cohort of preterm infants whether if combining lung ultrasound, pleural abnormalities, consolidations, and so on, increase the prediction of BPD, to try to use them as a clinical tool for a clinical trial of postnatal corticosteroids, but we are not at that moment yet. So we cannot give evidence-based recommendation, but we are beginning to use it for this purpose.
That's really helpful. Thank you so much. I've got a question from Alberto. Alberto, are you able to unmute and ask your question?
Yes.
Go for it, Alberto.
I thank you for a wonderful lecture, Professor Almudena. I wonder if it's not time to include this score in the BPD calculator. What do you think about that? We just use some information about gestational age and weight and FIA2, but this information is so important that I wonder if it's too yet, or it's not time to include in those calculators that we are seeing worldwide.
Well, you are asking the wrong person. I think I'm a believer. And if I have to make an answer to that, I would say yes. The problem is that not all units do have access to an ultrasound machine. So if we give some recommendations on its use, we have to realize that it's not accessible to many units. So it's something that it's increased, been used, at least in Europe, but also in other regions of the world. But we are not in the moment yet to say that this is something that has to be compulsory, because it's not accessible worldwide. But if you have it, of course, use it, because as you can see, it has an increased the information that you received using it is much more than the harm that you may do with your patients. It's something that you may add to the clinical evaluation, respiratory parameters that the baby needs in the ventilator, the clinical evaluation, and lung ultrasound also gives you more information about how their lungs are progressing, not only in BPD, but maybe patients with a PDA or infants with other diseases related to extreme prematurity, and of course for me the answer will be yes, but this is not yet something that's universally adapted to be included in protocols. However, we are now in a expert consensus group in which we will have some information, I hope at the end of this year, some clinical evidence-based guidelines on functional uses of neonatal lung ultrasound. We hope that we may have some recommendations on this line in a few months.
Thank you.
Welcome.
Dr. Ashraf?
Yes.
Please go ahead.
Good evening. Thank you, Dr. Almudena. Nice lecture. Really, I have two questions. First one, the last three cases you present, you start to give medicine, dexamethasone, diuretics, even nitric oxide, as 36 weeks. My question, why after spread of the lung ultrasound, we can use this early as prediction after 2 weeks? We can make intervention to decrease the risk of the baby to develop morbidity. This is the one. The other one, which better score for the prediction? It is classical one or modified one? And what cut off value for the prediction, the score, and which one, 7 days or 14 days? Thank you.
Okay, thank you. I think I understood in the first question that you want me to talk about BPD prediction using inhaled nitric oxide, diuretics, and so on. There's no evidence that these treatments decrease rates of BPD, and not at all, nothing. So we don't use it to decrease it. It's just something that we use as a rescue treatment in severe forms of the disease in infants with severe pulmonary hypertension or pulmonary overflow or so on. And in terms of using classical or extended lung ultrasound score, the evidence says that using just classical lung ultrasound, we can have quite a good view of how lung is progressing in this population. We don't need to do the extended to see the risk of developing BPD. Although we use it because it's useful for our daily management in these babies. We can see atelectasis that can be recruited, change in position of the infants, changing supine to prone or lateral position, or maybe the tube is too deep and we can reposition it. This is something that we use for daily management, but we don't really need the posterior areas of the lung to see the risk of developing BPD, because even though the patients have huge atelectasis in the posterior areas, this is not related to increased risk of BPD. And this is not only for BPD, but also for RDS or aspiration meconium syndrome, the evolving disease that also affects posterior areas of the lung does not increase the risk of bad prognosis in term or preterm infants in any disease. And I don't remember. Yeah, when is the best moment? No. Of course, the prediction of BPD increases when the baby gets older. The risk of developing BPD is higher when the baby has high lung ultrasound score at 28 compared to 29, 21st, compared to 14, compared to 7 days. But we have to realize that the sooner is better. When we have information as soon and as early as 7 days of life, we have to use it, and we can monitor and we can have a risk of developing chronic lung disease as soon as 7 days. But you know that the area under the curve, the prediction of chronic lung disease increases when the baby gets older. but maybe it's too late to try to get some preventive treatments for these babies.
Yes, thank you.
That brings
Thank
me
you.
to one question that I have, Dr. Almudena, and that is really that we tend to kind of define severity of BPD in particular at about 28 to 30 days. But we now know from a lot of work that's been done that actually the intervention for steroids is a lot earlier. And the question from our perspective is, morphologically, we can now see using functional lung ultrasound, as well as not just the scores, but actually how lung disease might evolve. Is it time to start changing the definitions for BPD? Because we've relied on oxygen, which is quite a late marker. Actually, there's a lot more information that is now available on lung ultrasound, scores and morphology much earlier. And
Yes.
is it time to push for that?
Not time yet. We don't have so much evidence to change that diagnosis, but maybe in the future, as you may say, we can try to more or less create different groups, because we have something called BPD as a whole. But when we see the different patterns, the different phenotypes described by people from Philadelphia a few years ago, we say that there are different diseases all together in the same box. There are some patients we have that have a more severe form of the disease related to airway problems, another related to pulmonary hypertension, and we more or less can monitor this using lung ultrasound. This is something that's quite early yet to say that we are on time to use lung ultrasound to change or to describe different phenotypes of BPD, but we are also on the way. And maybe in the future we could, as you say, maybe not change the definition, but maybe try to give specific treatments to the patients with specific different diseases, and not trying to use the same treatment for all of them, because the pathophysiology is completely different, and of course the response to treatments maybe would be.
That's really helpful. We've got a question from Surjit. Surjit, go for it.
Yeah, good evening, everyone. Ma'am, I want to know what is the cutoff value at 7 days of the lung ultrasound score to predict the high risk of BPD? And another question, what is the cutoff at 7 days of lung ultrasound for which we can start steroid between 7 to 14 days? Are they different, or like what do we take as a cutoff?
Well, if we have the whole population of preterm infants born before 32 weeks, cutoff value of 8 points would be good to predict BPD. But as we were saying, this is not enough for infants born before 38 weeks. We also have to rely on pleural line abnormalities, a small consolidation, atelectasis, and this is not just the number of lung ultrasound. The idea would be that if you see a patient at 7 days of life that still has a severe cholestin B pattern and alveolar interstitial syndrome, that patient is in risk of developing BPD. As a whole population of preterm infants would be an idea, maybe more easy to use than just the small number of 8. I hope I answer your question.
Do we start some very low dose of dexamethasone after that, like around 10 days or?
Well, there's no published trials using this approach. Maybe in the future we may have some, but we cannot give you a scientific-based recommendation on this issue. I'm sorry.
That's really helpful. Does anybody else have any other questions?
Look, can I ask a question?
Please go for it, Anna. Yes, please.
Hi, Almudena. Thank you for your nice talk.
Thank you.
I see babies with 30 days of life and they are under respiratory support because without it, they have polypnea or low sets. But the lung ultrasound is pretty normal. So they will be classified as having BPD, but in the lung ultrasound, there is no signs of it. So I think really we have to rephrase all our thinkings or our definitions because of lung ultrasound is showing us different appearance of the lung in these babies.
Well, you mean babies, extremely preterm infants that do have normal lung ultrasound at 20
Not
days of life?
extremely, after 30 weeks, 31, 32 weeks of life. And that at 1 month, they still need respiratory support without oxygen, but the CPAP or high flow nasal cannula. But the lung ultrasound is pretty normal.
You mean an interstitial pattern, some
Yes.
isolated V lines? Yes, that's quite usual. That's a mild form of BPD. Maybe it can be
Sometimes-
related to pulmonary hypertension as well.
Okay.
No?
Sometimes
Have you
actually
tried-
a profile with
But,
no lines.
without pulmonary hypertension? Have
Well,
you performed echocardiography
no.
as well? No.
No.
Maybe you could try to rule out pulmonary
Okay.
hypertension. Maybe it's not. It was what Elak was saying. A BPD is a box in which we have babies. At the end, we are defining a disease just with the need of FiO2, but this is not the point. We have patients, as you are describing, that do have quite good aerated lung, but the main pathophysiology is related to pulmonary hypertension or problems with their airway, but they also enter in the diagnosis of BPD. So maybe it's more or less the thing that your babies that you are describing may have. I don't know.
Yes, thank you. Thank you.
Thank you.
I think Almudena is absolutely right that, for those babies, they might have a delay in their pulmonary pressures coming down. We also know that some babies can have the Wilson-McAtee kind of clinical picture where they don't need a lot of respiratory support at birth, but continue with the symptomatology, but actually chest X-ray shows virtually a very mild ground glass appearance, and you probably get, what is A profiles everywhere. Or some of these babies can have significant PDAs sometimes as the PVR drops, but not severe enough to give you lung changes. So, it's keeping that differential in mind. And, the description of phenotypes, uh, while restricted to a lot of extreme preterm kind of management, and I would say the late preterm group under 28 weeks, uh, I think there are, the odd 30, 31, 32 weekers who sometimes need oxygen. The majority of them actually tend to do well, would be the overall feeling for most of us. But, I think it's keeping that kind of approach of thinking about doing an echo, thinking about the airway. It's interesting how some of our babies, with this can have elements of laryngomalacia, which can sometimes compromise things, have an increased tendency to having reflux, which, I personally don't believe I would treat necessarily, if it's very mild. But these are all things that can influence that group of babies. Any other questions? I think I would like to take the opportunity to thank Almudena. It's an absolutely beautiful area. It's an area that I think we are going to start developing in our unit over the next, I'd say, 12 months, and that we've just introduced a lung ultrasound guideline. But clearly, as I mentioned, having guidelines on less invasive surfactant, as well as I would say BPD management from a functional perspective, can be really helpful in terms of us trying to inculcate practices that we then practice in a kind of a uniform evidence-based manner. So one of the projects that we're going to discuss as a group for this group of colleagues, for the last group, it was development of just a generic guideline, which I've shared with the group today. But I think for this group, now that we've kind of covered BPD, the two areas that we'll be looking at over the next month will be developing some guidance on LISA and coming up with a guideline on how people might want to approach BPD. So thank you so much for the motivation, for the talk, for all the knowledge imparted. And I can't thank you enough. God bless you. And thank you everyone for attending today.
The pleasure is mine, Alok. You know it. Thank you for allowing me to be here. Thank you for this time.
Thank you so much. Thank you, everyone.
Thank you.
Thank
Bye.
you. Thank you.